Hi docs, this is Dr. Yasmin from Royal Docline. I welcome you all to the 5 minutes guideline series, and let's move towards the first guideline, which is Amniocentesis and Chorionic Villus sampling. This is a green top guideline number 8, and this was updated in 2017. We will be discussing the guideline under the following layout: introduction, gestational age, timing of the test, consent, technique, special circumstances, the risks associated with the procedures, training and maintaining the good practice, and summary. Regarding the introduction and the gestational age, 5% of all the pregnant patients, which is about 30,000 in the UK, annually they are given the choice of invasive prenatal testing, which includes amniocentesis and the chorionic villus sampling, which you can see is mentioned by CVS. Gestational age is very important. Amniocentesis is usually the method of choice, and it is done at 15 weeks onwards. If it is less than 15 weeks, this is called early amniocentesis, which is associated with more fetal loss and increased incidence of the fetal talipes or the respiratory morbidities as compared to the CVS. CVS or the chorionic villus sampling is done at 11 weeks to 13 weeks and 6 days, and the early CVS, which is less than 11 weeks, is associated with the oromandibular defects, limb hypoplasia. However, isolated limb disruption defects has been debated. The additional risk of the miscarriage for the amniocentesis is about 1% above the background risk of the miscarriages. The consent, of course, over here is very important, and the consent form number 3 is used. This is exam question, and this is by the Department of Health. This should be a written consent. However, you have to discuss the consent in detail with the patient, like how it will be done, what are the risks associated, what are the complications, what are the accuracy and limitation of this test, and if she develops some problem after the test, she needs to come to the hospital for having any medical advice. And don't forget about the NTD if of course the woman is RH negative. The technique, training and the maintenance of the good practice. It is done under the ultrasound guidance, and the fetus is mapped about, placenta is mapped about. Try to avoid the placenta because it can damage the placenta. However, if not possible, you can go through the transplacental approach. The needle size is important, which is 0.9 millimeter, and it is equal to about 20 gauge. This is an exam question. There is no need to give the local anesthesia, and the randomized controlled trials are showing that there is no reduction in the pain. If you use a local anesthesia, only 4% of the specialists in the UK, they use a local anesthesia. However, the training and the maintenance of the good practice is always a part of the patient safety, and the operators are trained by Advanced Training Specialist Module, which is called ATSM by the RCOG, and he or she should have 50 to 100 procedures per annum. If the fetal loss rate is 4% in amniocentesis or 8% for the chorionic villus sampling, it means this person needs to have a continuous audit of the complications, and they include the need for second insertion, blood tap, or failure to cut the sample, and the miscarriage rate. There are few special circumstances like the multiple pregnancy. Here you have to do the detailed counseling of the patients. Separate samples are taken in dichorionic twins. Separate needles are used to avoid the trans-contamination. A specialist who is able to perform the selective termination should do the multiple pregnancy. And you should inform the woman that the miscarriage rate is likely to be higher than the singleton pregnancy. Regarding the third trimester amniocentesis, it is done usually for suspected infection in the preterm pre-labor rupture of the membranes. However, the complications, including the multiple attempts, blood-stained fluid, and higher culture failure rates are more commonly with the third trimester than the second trimester. The risks are usually the severe sepsis, and it is about 1 over 1,000 procedure. This is an important incidence, and the care of the probe should be taken. Sterile gel should be taken. Blood-borne viruses should be screened before you perform the procedure, like hepatitis B, hepatitis C, and HIV test is also very important. Try to avoid amniocentesis or the chorionic villus sampling in HIV patients. And if needed, you can do a rapid HIV test if it is an emergency situation. Otherwise, the viral load and the patient's fitness for this test is important. Here is the summary that how many women they are provided with this prenatal testing, needle size and the timings, miscarriage rate, audit, all of these things have been discussed over here. Let's move to the original Amniocentesis and Chorionic Villus sampling guideline. And here are all the marked areas which I have already presented. And you can see how the guideline has been marked. These are all the important points. I would appreciate if you like our channel, subscribe to our channel and share it with your friends. Thank you. Have a nice one.